Thank you for listening to Depictions Media Radio. Welcome to Policy and Rights, the show about human rights and government policy. Welcome back, everyone, to Policy and Rights here on Depictions Media. I am Michael, and today we're going to start off with Jagmeet Singh, and he is going to be talking about a report, and this report is the impact of COVID-19 on long-term care in Canada. And first off, he's going to tell you that Canada has gotten the worst report out of all of the developed countries in the world. That would include countries like the United States and Britain and other developed countries like that have retirement and long-term care programs for the elderly. So, first off, this report states that LTC and retirement homes have been disproportionately affected by COVID-19 in Canada, and the pandemic experience has not improved overall for the sector in the second wave. The second wave in Canada was bigger, broader than the first wave, reaching more parts of the country and resulting in large number of outbreaks, infections, death in long-term care and retirement homes. The pandemic experience varied greatly between provinces and territories and between COVID-19 waves. In fact, the second wave hit harder, causing more deaths than the first wave. And Jagmeet has been talking about this ever since the first wave, where there were numerous deaths in different provinces in retirement communities. So the next point was the long-term care residents received less medical care during the first wave of COVID-19 than in normal years. Compared to the pre-pandemic years, long-term care residents have had fewer physician visits and were less often transferred to hospital for the treatment of chronic conditions and infections. They also had fewer contacts with friends and family, which were associated with higher rates of depression. The third point out of this report was the number of long-term care resident deaths was higher than usual during the first wave of the pandemic in all provinces where it could be measured. The total of resident deaths caused from higher during the first wave lockdown than in the same period of the pre-pandemic years. Even parts of the country with fewer COVID cases and outbreaks. So, in the fourth point, recommendations for provinces and national inquiries to date on the COVID-19 in long-term care homes are similar to speak to the structures of challenges in the sector. This includes needing increases staffing, stronger infection control, prevention practices, better inspection and enforcement of processes, and improvement building infrastructure to reduce crowding and infection spread. So, it would seem that the staff, while they are understaffed, they are also needing better training and better regulation on what is going on. Jagmeet has said that instead of having completely private care in most of the long-term care homes, he has proposed that there would be a crown corporation to govern what is actually going on. So let's listen to Jagmeet's comments to the press on this.
Thank you very much. Thank you so much, everybody, for being here today. I want to start off by talking today about the report that came out yesterday. Very damning report and very troubling report that points out that Canada performed the worst in the developed world in terms of countries that are similar, well-developed OECD countries. That Canada had the worst rates of mortality for seniors in long-term care. I've said before, this is a national shame. What's also become clear is that Canada did worse in the second wave than in the first wave, meaning that the problems that we saw in the first wave were not fixed. And that's why, again, we call on Justin Trudeau to remove profit from long-term care, which we know is directly related to worse conditions of care, more infections, and more deadly infections. We need to improve conditions of work, which are directly tied to conditions of care. We need to do this immediately. We also know the government has announced a plan to invest in a private company for the capacity to produce vaccines and drugs in Canada. Our concern is, where are the strings attached? How do we know that this is not going to be another example of public money, our money, going to a private company that ends up leaving the country years later and no support left for Canada? That's why our plan, which we called for months ago, continues to be the best way and the best approach. We need to make sure we've got publicly owned capacity to produce vaccines and critical drugs, the way we did in the past with Connaught Laboratories. We need a Crown Corporation, a publicly owned facility that produces these vital life-saving vaccines and medication. That is the way forward. Donc, hier, on a vu un rapport qui montre que le Canada était le pire en taux de mortalité pour nos aînés dans les centres de soins de longue durée. C'est quelque chose qu'on, j'ai appelé une honte nationale. Et c'est vraiment une honte nationale. Le fait que nos aînés étaient les plus frappés par la COVID-19 et le fait que la deuxième vague de la COVID-19 était pire que la première vague de COVID-19. Ça veut dire que le gouvernement libéral n'a pas appris des leçons et n'ont pas agi de protéger nos aînés. Ça, c'est pourquoi encore on exige du gouvernement d'enlever les profits des centres de soins de longue durée et d'améliorer les conditions de travail qui sont complètement liées aux conditions de soins pour nos aînés. On doit agir tout de suite pour protéger nos aînés. Deuxièmement, le gouvernement annonce aujourd'hui qu'ils vont avoir un partenariat avec une compagnie privée pour produire les vaccins et les drogues essentielles dans l'avenir. Le problème avec cette proposition, c'est quoi la garantie que cette entreprise va rester au Canada et que ça ne va pas être la même chose où on donne de l'argent public aux entreprises privées qui prennent l'argent, mais après des années, quittent le Canada. Ça, c'est pourquoi encore on propose notre solution, quelque chose qu'on a déjà annoncé il y a quelques mois, qu'on doit avoir une société d'État où nous, les Canadiens et Canadiennes, sont les propriétaires, une société d'État qui produit les vaccins et les drogues essentielles, quelque chose qu'on a déjà eu dans le passé avec Connaught Laboratories. Donc, c'est exactement ce qu'on a besoin maintenant, d'avoir la capacité de produire ces vaccins chez nous au Canada et une capacité qui où les Canadiens sont les propriétaires. Donc, ce sont mes remarques d'ouverture et je suis prêt pour vos questions. I'm ready for your questions. Thank you so much.
Merci beaucoup. Alors, j'invite les membres des médias d'utiliser la fonction lever la main pour poser une question et une question de suivi. I would like to invite members of the media to use the raise hand function at the bottom of the page to ask a question and a follow-up. I will start with Chris Reynolds with the Canadian Press. Please go ahead.
Hi, Mr. Singh.
Hey there, Chris. Good to see you, sir.
You too. So you are fresh off of your tour through Quebec and Montreal. One thing I'm wondering just how essential winning some seats would be in a potential election this year in Montreal and the broader area is to the NDP's overall plan. Like, is this a key path forward to even greater electoral success?
We certainly want to be able to represent Canadians across this country. We want to have a strong presence in Quebec. It's because people need us. And when I was in Quebec and hearing from people came to me and asked them what they were concerned about. And without any prompting and beyond asking them what they're worried about, I met a woman who told me she literally has to choose between some days buying food or medication. And that was heartbreaking to hear her say that. But I told her we were going to fight for pharmacare for all. And she almost teared up saying that would mean the world to her. I met a young man who was worried about owning a home and being able to buy a place. And I said, we are going to fight for affordable housing. I spoke to a lot of young people telling me about their concerns around mental health. And we know that these are real concerns for young people, particularly. There are a lot of people that need our help and see in us a real champion fighting for them, fighting for the things they need. And I would be honored to serve more Canadians in general, but particularly to your question, I would be honored to serve more people in Quebec. And it is vital for us to be able to represent these good folks and to be able to fight for them.
En français, s'il vous plaît.
Okay, Chris, I'm going to just do that response in French, and then I'll come back to your follow-up. On veut représenter tout le Canada. C'est important pour nous de représenter tous les endroits à travers le Canada, mais la question était spécifiquement pour le Québec. Et oui, bien sûr, on veut représenter les gens au Québec parce qu'ils ont besoin de nous. Et pendant ma tournée au Québec, j'ai parlé avec plusieurs personnes et ils ont partagé leurs craintes. Je me souviens d'une femme et elle a été tellement excitée de dire « Allô » et j'ai dit « Est-ce que vous avez des craintes, des inquiétudes ?» Et sans leur donner plus de ça, elle a dit qu'elle doit choisir entre la nourriture et les médicaments. Dans sa vie, c'est un choix qu'elle doit faire tout le temps. Et ça brisait ma cœur d'entendre ça. Et j'ai rencontré des autres jeunes et ils ont dit qu'on a des misères à trouver des services de santé mentale. Et je sais que la santé mentale en général, la santé mentale était un enjeu, mais c'est toujours un enjeu, particulièrement pour les jeunes qui étaient vraiment frappés fort par la COVID-19. Et j'ai parlé avec un autre qui a parlé de le problème de logement, le fait qu'il ne peut pas aborder un logement, un appartement, une maison, et il veut acheter, acheter. Donc, pour ces gens, nous proposons une solution concrète pour les aider et ils ont besoin de nous, ils ont besoin de notre voix et on va continuer de se battre pour eux et je serai fier de les représenter avec plus de députés parce qu'ils ont besoin de nos aides.
Some opposition parties at the provincial and federal level recently have been hammering on hot button issues, sensitive issues that might be described as cultural touch points or issues of identity and even blowing some cultural dog whistles. I'm wondering if this is also a concern for you in the lead up to a potential election this year in the wake of discussions about protection of the French language, in the wake of discussions of even of ethnic identity. How concerned are you that this will be a barrier or actually maybe an opportunity?
Sorry, just a moment here. I'm just having a minor technical problem.
No problem.
I think at the end of the day, what people are talking to me about, what they're concerned about, are issues related to the pandemic. That's the biggest issue. You know, premiers might be raising other issues, but what I'm hearing, people are worried about the pandemic. They're worried about their loved ones not being able to have access to the vaccine. That's something that people talk to me about. People are worried about not being able to afford a place to live. People are worried about their health care and whether it covers them when they need it. These are things that people are talking to me about, and these are exactly what we are going to fight for. So for the things that matter most to people, making sure their loved ones are cared for, have the medication they need, have the mental health supports and the dental care, frankly, that people need access to, affording a home, and making sure the burden doesn't fall on people, but instead on the ultra rich to pay their fair share. These are things that speak directly to what people are going through. So I'm going to continue to listen to what people are worried about and champion the things that matter to them. And across Canada, people are worried about discrimination, whether it's discrimination in Quebec of people based on the French language. That's been a historic problem, ongoing problem. People are worried about systemic racism, which means people are being precluded from opportunities, from participating because of the way they look, because of the color of their skin. Women continue to face challenges getting back into the workforce. These challenges are all really the same in the sense that there are people that are being faced with barriers because of who they are, and New Democrats are all about finding solutions to support people and make sure that no one's left behind. And each of those struggles are unique, but really bring people together in that we want everyone to feel welcome, everyone to feel like they can thrive, and everyone to feel like they belong. And that is what we're all about.
Thanks.
En français, s'il vous plaît. En français, s'il vous plaît, Jagmeet, est-ce que tu m'entends?
Oh oui, maintenant je peux. Donc, quand je parle avec les gens, ce qu'ils soulèvent comme enjeu, c'est le fait qu'ils ont des peurs par rapport à la pandémie et ils veulent avoir plus des vaccins. Ils veulent voir la vaccination fonctionne et c'est exactement la même crainte qu'on a aussi. Donc, on va continuer de pousser pour vacciner toute la population aussitôt que possible, aussi rapide possible. Donc, ça, c'est quelque chose qui les gens soulèvent comme concern. Aussi, les gens parlent de le problème de logement et comment c'est difficile d'aborder le logement. On a une solution pour ça. Les gens parlent de santé en général, les soins de santé, et comment c'est important d'avoir accès aux soins de santé. Encore, c'est nous, les néo-démocrates, qui proposent des solutions concernant comment on peut améliorer l'accès aux services de soins de santé. Donc, pour les enjeux qui touchent les gens, c'est nous, les néo-démocrates, qui proposent les solutions. Et aussi, les gens ont peur que peut-être toute la pression de comment on paye la facture pour la relance tombe sur leurs épaules. On a proposé, on est le seul parti, les néo-démocrates, qui propose que les autres riches doivent payer le juste part au lieu de mettre la pression sur monsieur, madame, tout le monde. Et finalement, concernant l'enjeu de discrimination, je crois que c'est un enjeu qui unit toute la population parce qu'il y a plusieurs personnes qui font face à la discrimination. On a la discrimination basée sur la langue qui existe et qui présente un problème. Et c'est un problème historique et un problème qui continue. Donc, nous, les néo-démocrates, veulent faire face à cet enjeu en assurant que tout le monde peut avoir accès aux services dans leur langue et en défendant les langues minoritaires. C'est essentiel. Aussi, on sait qu'il y a des impacts dans la société basés sur la race. Le racisme systémique, c'est encore une autre forme de discrimination qui crée des barrières pour quelqu'un seulement à cause de la couleur de la peau. Donc, les néo-démocrates veulent bâtir une société où personne n'est laissé à côté. Et c'est exactement pourquoi vous pouvez trouver en nous des alliés pour bâtir une société où personne n'est laissé pour compte. Et on s'assure que tout le monde est bienvenu pour que tout le monde puisse participer dans la société. On a une meilleure société où tout le monde est bienvenu et tout le monde peut participer. Et c'est exactement ce qu'on veut bâtir.
Merci beaucoup. So I have a question from Mary Brooke from Island Social Trends. She sent it through the chat line. So I will read it. Yesterday, NBC, the agriculture minister, said that food security in the province depends on about 11,000 temporary foreign workers to work in food, fish, and farm. She said these are jobs open to young people. How can the younger generation be incentivized into other job sectors after this pandemic?
I appreciate the question. Food security is very vital, so I appreciate the question. We need to always be looking at policies that help us ensure that we've got the capacity to feed our own nation, that we can feed ourselves with the resources that we have here in Canada. So that question really speaks to me, speaks to the fact that we've got to have better policies in place to support farming and to make sure farming is a viable and a successful opportunity for someone in terms of a career. But the question specifically around encouraging young people, I think this is very vital in our recovery. We have to acknowledge that a recovery is not strong if it leaves people behind, and particularly if it leaves those behind who are hardest hit by the pandemic. So while there are some positive job numbers or positive forecasting coming out, not job numbers, but forecasting, I'm worried that the forecasting just means return to economy as usual, where women aren't supported who've been hard hit, young people aren't supported who've been hard hit. So with young people, we need to have a clear approach that specifically incentivizes and supports young people to get back into the workforce. And if it happens to be also in food security and food production, then we need to make sure that there's a clear path of incentivizing and supporting and encouraging this work and encouraging young people to take part in it. I think policies determine outcomes. And if we have the right policies in place that acknowledge the importance of food security and making sure young people are a part of the recovery, we can achieve the goal of getting young people involved again.
Okay, so Jagmeet is proposing a lot more government input into the economy, into long-term care, and into ensuring that that people are being seen on an equal basis. The question is more government involvement really going to do what it's supposed to do? It has been seen in the past, and it has also been seen in the current government that if there's a way to get a kickback off of government involvement, that somebody's actually going to take it. So maybe there's a better way, a better platform for government to be able to support people that would negate the idea of some other corporation being able to get a kickback from what citizens need and the average everyday people need as support and equal terms. So that would be one of the major comments on what Jagmeet is actually proposing, because there's a lot of minorities out there that simply by way of looking at the pandemic have been left behind, and it looks like that government is going to still leave them behind, or just put a Band-Aid on what the overall problem is. So what Jagmeet may be proposing could only be the beginning of a really good start, but it isn't actually going to fix the problem with a crown corporation. There needs to be more than that to happen in order to equalize what we've seen out of this pandemic. Okay, so let's move forward. Okay, so let's examine what's happening all over North and South America. When it comes to equality, we are looking at an inequitable state that, while Canada and the United States have managed to be able to procure a lot of vaccine to help our countries, which is really a great thing, there has been some criticism towards Justin Trudeau that Canada is much far behind other developed countries in actually vaccinating people, but vaccinating Canadian citizens. But at the same time, Canada actually has managed to vaccinate a large number of people, and they're moving along quite well through most of the provinces at getting the elderly vaccinated and people that have essential jobs that put them at risk for infection of COVID-19. So things are actually moving along through Canada, and they are moving along through the United States. But let's look at some of the other countries, like say Brazil, Paraguay, and a few other countries in South America where they're having trouble getting hold of the supplies, equipment, and vaccines. That it is an inequitable state, and some things should make sure that are happen to ensure that things are moving on an equal basis just around the world, making sure that the vaccines and everything are actually being spread equally around the world, so that as the vaccines and healthcare equipment and protection equipment move around the world, that we are immunizing the entire human population globally at the same time, and that we are making sure that different countries aren't racking up huge bills that may never get paid back for the equipment and medical care that needs to happen for this particular pandemic. So let's listen to what the Pan American Health Organization, Dr. Etienne, actually has to say about what's going on with the pandemic in North and South America, and we'll also listen to some of the question and answer period that will appear after her opening statements.
Greetings and good morning. Welcome to this press briefing on COVID-19 in the region of the Americas on March 31st, 2021. We apologize for your patience and thank you for continue being connected to us. This is Sebastián Oliel from the Communications Department of Bajo, and the session will last around an hour, and we will be taking questions from you up to that point. We have received questions by email, and you will be able to ask your questions live and also using the Q&A button. Always remember to include your name and your medium when you send your questions to us. Also, we have simultaneous interpretation to English, Portuguese, French, and Spanish, and you can use interpretation facility through the interpretation button. Dr. Carissa Etienne, Director of PAHO, will give us some words regarding the first 3 months of this year, 2021, about the pandemic and the technical cooperation from PAHO during this third quarter. Dr. Jarbas Barbosa, Assistant Director of PAHO, the Director of Emergencies, Dr. Ciro Garta, and Dr. Silvana Righetti, Director of our Manager of Incidents for Emergencies, are with us. Dr. Etienne.
Good morning and welcome to our press briefing. Our apologies for starting late. This is the last day of the quarter, and I just wanted to take this opportunity to take stock of the pandemic in our region since the start of 2021. Since January 1st, 2021, there have been over 19.7 million cases reported in the Americas, and we have Brazil, Chile, and Paraguay have been reporting the highest rates. The recent influx in cases is overwhelming hospitals in several countries. For example, ICU occupancy rates are over 80% in all but 2 Brazilian states, and Jamaican hospitals are operating well above capacity. Mortality increases when this happens because patients have difficulty finding the care that they need, and health workers are overburdened by tending to too many people at once. Today, the pandemic is as active as ever, and we have no option but to fight it. In fact, a few countries in our region, including Paraguay, Uruguay, and Cuba, are experiencing outbreaks in 2021 of greater magnitude than the ones that they faced in 2020. All countries of the region should be on high alert. In this pandemic, complacency leads to more cases. We urge our member states to reinforce surveillance and act at the first sign that cases are rising. Don't wait until you are overwhelmed. The risks for your people and health systems are just too high. The past 3 months have marked a critical phase of the COVID pandemic for our region. And there have been 3 areas where PAHO has been especially focused. First, our surveillance network has been significantly expanded to identify and track variants of the SARS-CoV-2 virus. 21 countries are now participating in our COVID-19 genomic surveillance network, giving us a much better picture of the variants circulating in our region. At least one of the 3 variants of concern have been identified in 32 countries and territories of the Americas. And we are working hand in hand with member states to increase their capacity and to improve reporting of these variants. We are also conducting analysis to better understand the real impact of these variants in some of the most highly affected areas. A technical consultation on variants this week concluded that the message remains the same. It is important to continue and strengthen genomic surveillance, but what we must do to prevent transmissions with or without circulation of virus is to maintain the public health distancing and control measures that already exist, including now vaccination. And these measures have not been modified in any way. In terms of vaccines, immunization is another high priority topic for us in the Pan American Health Organization. On January 1st, only a handful of countries were vaccinating against COVID-19 in our region. This picture has changed. As of yesterday, 124 million people have received at least 1 dose of vaccines in the Americas, and more than 58 million have completed their vaccination schedule. Almost all our member states are rolling out vaccines. Haiti will soon follow suit as the first shipment from COVAX arrives in the coming weeks. COVAX shipments have reached many participating countries, enabling us to protect at least some of the populations that are at greater risk. In an effort coordinated by the PAHO Revolving Fund, more than 2.5 million doses from COVAX have arrived in 17 countries in our region in the last 30 days. This week, Guyana, Bahamas, Belize, and Trinidad and Tobago are getting their first shipments. But as we celebrate progress, we cannot close our eyes to the fact that vaccine supply continues to be our greatest challenge. A large part of this is due to delays in production as manufacturers rush to scale up capacity. But we are also seeing for too many examples of vaccine nationalism, which limits global availability even further. The current system is hardwired for inequity, and that is not acceptable. Vaccines should be available to all who need them, regardless of where they live. PAHO remains a champion for equitable vaccine access, and we will continue to fight for more supplies until our region is fully immunized. Vaccines, though, are not the only scarce resource in 2021. As cases have risen, some member states have faced shortage of supplies that are essential to protect personnel and to treat cases. In the first few months of this year, the availability of oxygen and anesthetic medicine has been threatened by the speed of new cases that are flooding hospitals in Brazil, Peru, and other places. This underscores the dire consequences of a pandemic that can quickly overburden our health systems. That even a well-established supply chain is struggling to cope. Our third area of focus has been to accelerate the procurement of drugs and PPEs that are needed on the front line. This year alone, PAHO has helped procure more than 3 million units of medical masks for the region, and we are actively supporting governments every day to find solutions for oxygen and other supply limitations. As cases rise, we will continue to support countries to secure the PPEs, the drugs, and the other supplies that they need. As vaccines arrive, we will do our part to ensure that they are delivered as quickly and equitably as possible within countries. But we don't have enough vaccines right now to stop active outbreaks. This requires much broader coverage than is possible at this time. So until then, we must never forget that prevention is always the best option. And we do know exactly how to prevent this virus. PAHO keeps track of and analyzes mobility data from internet and phone companies, and we see time and again that as the population in certain areas leave home more frequently, that cases rise. When holidays come and people from different households meet indoors, cases rise, as they do when people travel more. So summer is ending in the Southern Hemisphere, and it is no accident that the vacation season is being followed by a rise in cases in several countries. Without preventive action, our region could face an upsurge that is even larger than the last one. So let me be as clear as possible. My main guidance for places experiencing surges in transmission can be summarized in 2 words: stay home. If you can avoid having others over, avoid it. And if you must leave your house, wear a mask, wash your hands frequently, and stay away from crowded spaces. You know, this is a shared responsibility. In a region as unequal as ours, where many rely on informal income, governments must support their people to allow them to stay home. We all have a role to play in following the public health measures that have been put in place to protect our communities. This is how we save lives, and this is how we beat COVID-19. Thank you.
Muchas gracias, doctora Etienne. Vamos a pasar
Thank you very much, Dr. Etienne. Now we are going to go to questions and answers. We have several here, and we are continuing to receive questions in the Q&A and the chat. The first question is from CNN radio in Argentina. The question is, could the COVAX mechanism broaden to supply, instead of a maximum of 20% of the population, 80% of whatever is necessary, so that all countries may be able to immunize their population? And this is from Desiree Jaminovich. She says also that she was looking at numbers in her country and region, and there is a big gap between the contracts signed and the vaccines reaching the countries, and she wants to know, why is this happening? What factors may have generated these gaps between purchases and deliveries? How could this be improved? Dr. Barbosa. Thank you very much for your question, Ms. Demovich, regarding how to increase the 20%, which is the first goal for COVAX. That 20% is related to the most vulnerable groups of the population. It is estimated that in each country, this 20% would be enough to include the elderly, adults with a chronic disease, which will be a risk for developing a more serious form of COVID-19. But without a doubt, we need to go beyond. The objective is to have enough vaccines to vaccinate all persons who need to be vaccinated in order to reach, together with public health measures, the control of transmission. PAHO is seeking to broaden access through COVAX, but also through negotiations with countries that purchased more vaccines than they needed for the population, to seek that those countries will donate a vaccine for the COVAX mechanism, especially for the Latin American and Caribbean regions, and also through the revolving fund, looking for alternatives so that it is possible to offer supplies of vaccines beyond the 20% of what the COVAX facility has committed to provide. Regarding that gap between the regions, I think the director has already underlined the issue of the need to have equitable access to the vaccines. If in the world we don't have a mechanism, an arrangement, an agreement among countries for access to happen equitably, what will prevail is the market rules. The richer regions, the richer countries are going to buy the vaccines, and COVAX and other facilities that have in mind equitable access will have difficulty delivering those vaccines. Toward the end of April, we are hoping to have a decrease, or up until April, we will have a decrease in the number of vaccines. The situation is different. There is a political problem in China and India, where the government is limiting the numbers of vaccines that are exported from India, and there are other situations. AstraZeneca has 2 new sites, one in Italy, one in Spain, that are going to begin to deliver vaccines for the COVAX mechanism, including for Latin America and the Caribbean, and we hope this will solve some of those manufacturing issues, and there will be a greater availability of vaccines for our region. Thank you very much. Thank you, Doctor. Next questions one related to the variants in English now from Luke Stephen Taylor from the British Medical Journal and from Terence McCoy from the Washington Post. The question reads,
is the situation in Brazil for the rest of the region? Is there a worry that it is a picture of what is to come elsewhere thanks to P1 variant? Also, what is the latest understanding of P1? Is it of concern? Y Terence McCoy del Washington Post pregunta también en inglés, does it appear that the P1 is playing a large role in driving the surge in cases in Latin America? Is there fear that the entire region, given shortcomings in medical capacity, could soon look as overwhelmed by the virus as Brazil? Dr. Alighieri?
Yes, thank you, Sebastian, for these two questions from the British Medical Journal and from the Washington Post. The actual situation in Brazil is the result of an increased transmission following both the Christmas and Carnival high movements of populations. I'd like to stress that during these two periods, the implementation of public health measures was suboptimal in most of the territory of Brazil, therefore triggering the amplification of the transmission and the wide geographic dispersion. We can say that the transmission of SARS-CoV-2 is high or very high in all regions of Brazil at the same time: north, center, northeast, southeast, and south. This is one of the main differences compared to the first wave in Brazil during 2020. As an example, during most of the last week, the daily number of deaths reported countrywide in Brazil was superior to the USA, which was the driver of the epidemic in the Americas during the second semester of 2020. The situation in Brazil reflects how the partial implementation of public health measures or the untimely relaxation of these public health measures can negatively impact on the dynamics of the transmission. In addition of the suboptimal implementation of these public health measures, I'd like to note that the circulation of the P1 variant of concern countrywide in Brazil is clearly contributing to the increase of cases. We observe that the P1 variant seems to be more transmissible compared to the wild type that was circulating during 2020. We are also receiving reports in different states of Brazil that young adults are hospitalized in ICUs in higher numbers compared to 2021. Regarding the spread of the P1 variants, in addition of Brazil, we have received reports of the P1 detection in 8 countries and territories of South America: Argentina, Chile, Uruguay, Peru, Colombia, Paraguay, Venezuela, and French Guiana. P1 was also detected in the 3 countries of North America, the USA, Canada, and Mexico, and in both French and Dutch Caribbean, and in Panama. What is the contribution of the P1 variant to the dynamics of SARS-CoV-2 in these countries is under investigation. I'd like to stress again and again, and following the remarks of Dr. Etienne, that the same public health measures that we used last year still work against the variants circulating in our region, including the P1 variant, initially detected in Brazil, and the B117, originally detected in the UK. In conclusion, I would say that countries that do not monitor closely their epidemiological, laboratory, and hospital indicators, and that do not timely adjust their public health measures would be at risk to face soon a highest burden of their health systems and would be at high risk to have their ICUs overwhelmed. I hope I have answered both concerns of both journalists. Thank you.
Okay, next let's listen to how the United States is actually doing versus COVID-19. And as we know, President Joe Biden has put in place a program that is activating several sites across the country to be able to cause a large herd immunity in the United States against COVID-19. There's very many injection sites to vaccinate and immunize people against COVID-19. So let's listen to what's happening in the United States right now.
And thank you for joining us. I'd like to begin this briefing where the President left off his remarks on Monday afternoon. As he said, we are in a life and death race against the virus. We are facing an accelerating threat. And faced with an accelerating threat, this administration is accelerating our response even further. The most powerful way to do this is to accelerate the pace of vaccinations. Starting on day one, we began working to accelerate and increase vaccine purchases and manufacturing to have enough vaccines to vaccinate all adults by the end of July. We then accelerated that to have enough vaccines for all adults by the end of May. The President then directed states to open up vaccinations to all adults by the beginning of May. But as we have seen this virus continue to spread, President Biden has ordered that his national vaccination effort accelerate to the next level. Within 3 weeks, by April 19th, 90% of adult Americans will be eligible for a vaccine, and 90% of Americans will live within 5 miles of a vaccination site. Already, there are more than 50,000 vaccine sites across the country. Within 3 weeks, there will be about 70,000 locations, as we nearly double the number of pharmacies that are vaccinating Americans. More Americans will get more appointments in more convenient locations. The President also committed to opening at least 12 more federally run mass vaccination sites. And today, we're announcing 3 new sites that will open next week, in addition to the 2 we announced on Monday in St. Louis, Missouri, and Gary, Indiana. The first is in Memphis, Tennessee, at the Pipkin Building at the Liberty Bowl Memorial Stadium. The second is in Milwaukee, Wisconsin, at the Wisconsin Center, and the third is in Greenbelt, Maryland, at the Greenbelt Metro Station. Each of these sites is the first federally run mass vaccination site in its respective state, and each is capable of administering 3,000 vaccinations a day. I can also report that previously announced sites in Massachusetts, New Jersey, Virginia, and Washington are now all open and fully operational. In total, we've opened 25 mass vaccination sites, which have a combined capacity to administer over 95,000 shots per day. These sites are run by the federal government in close partnership with state and local officials, and they're part of our work to equitably distribute vaccines and reach communities that have been hurt the most by the pandemic. Through these mass vaccination sites, we've administered more than 2 million shots in some of America's most at-risk and underserved communities. More than 60% have been administered to racial minorities. All these efforts are on behalf of one thing: saving lives. We need to keep case numbers down so we can save lives and give people the chance to get vaccinated in April, May, and June, so we can enter the summer on the strongest footing possible. Now, in the weeks ahead that it will take to get everyone vaccinated, for all of this effort, we need a simple thing of every governor, mayor, and local leader, and that is to heed what the President is asking in return: simply to maintain or to reinstate mask mandates. And we need every American to do their part. Together, we can win this race and save lives. If we're acting on our own, we will lose even more people. We're acting together. We can defeat this. And with that, I'm going to turn it over to Dr. Walensky and then to Dr. Fauci for some important updates from them.
Thank you so much, Andy. I'm glad to be back with all of you today. As per usual, I will begin with an overview of the state of the pandemic. CDC's most recent data show that the 7-day average of new cases is slightly less than 62,000 cases per day. We continue to see an increase, and this is almost a 12% increase from the 7-day period prior. Hospitalizations also continue to increase. The most recent 7-day average, about 4,900 admissions per day, is up from 4,600 admissions per day in the prior 7-day period. And the 7-day average of deaths remains slightly above 900 deaths per day. As I said on Monday, this is a critical moment in our fight against the pandemic. As we see increases in cases, we can't afford to let our guard down. We are so close. So very close to getting back to the everyday activities we all miss so much. But no, we're not quite there yet. We need to keep taking the mitigation measures like wearing a mask and social distancing as we continue to get more and more Americans vaccinated every single day. Since early in the pandemic, COVID-19 has disproportionately affected certain groups in the United States, particularly Blacks, Hispanic and Latino, and Native American communities. In mid-February, CDC released its estimates of life expectancy in the United States in the first 6 months of 2020, which showed a profound impact on communities of color, with a drop in life expectancy of 2.7 years among non-Hispanic Blacks and 1.9 years among Hispanics, historic and tragic declines in these populations. Today, CDC is releasing an MMWR that provides additional detail on provisional mortality in the United States for all of 2020, with a focus on deaths associated with COVID-19. In 2020, about 3.3 million deaths occurred in the United States overall. This represents a 16% increase in deaths from 2019. COVID ranked as the third leading cause of underlying cause of death after heart disease and cancer, with approximately 378,000 COVID-19 deaths, accounting for roughly 11% of all deaths in the United States in 2020. COVID-19 deaths were highest for older adults and males, and were higher, as we previously saw, among American Indian and Alaskan Natives, Hispanics, non-Hispanic Blacks, and non-Hispanic Native Hawaiian and Pacific Islander persons compared to non-Hispanic whites. In fact, among nearly all of these ethnic and racial minority groups, the COVID-19 related deaths were more than double the death rate of non-Hispanic white persons. Sadly, based on the current state of the pandemic, these impacts have remained in 2021, where we continue to see that communities of color account for an outsized portion of these deaths. The data should serve again as a catalyst for each of us continue to do our part to drive down cases and reduce the spread of COVID-19 and get people vaccinated as quickly as possible. I know this is not easy, and so many of us are frustrated with the disruption this pandemic has had on our everyday lives, but we can do this as a nation working together. There is reason to be hopeful because we now know so much more about this virus, how to stop its spread, and we now have 3 historic, safe, and effective vaccines that we didn't have just 4 months ago. And we are distributing billions of dollars into communities disproportionately affected to help mount the most aggressive, equitable vaccination campaign of modern times. Millions more people are getting vaccinated every single day. This week, we will cross the 100 million people who have received at least 1 dose of the COVID-19 vaccine in the United States, a remarkable feat in such a short period of time. Further, over 70% of people over age 65, our most vulnerable group, have received at least 1 vaccine dose. I'm proud that CDC stands with others leading the way to scale up our national vaccine effort as quickly as possible. As the President mentioned on Monday afternoon, we are working quickly to expand our federal retail pharmacy program from about 17,000 to 40,000 stores in communities across this nation to help everyone have ready access to vaccines. With this expansion and additional efforts in partnership with FEMA and states across the country, we will be able to reach the administration's goal of making sure that 90% of Americans will be within 5 miles of a vaccination site by April 19th. And we recognize that 5 miles is still too far for many Americans. And that is why we are activating resources such as mobile units and clinics to those communities where this is the case to ensure they can get access to vaccinations. CDC is also excited to partner with the Administration for Communities Living to support their efforts to get older, at-risk adults and those with disabilities vaccinated. This is helping to provide critical access to COVID-19 vaccines to these individuals. Finally, I want to briefly share that today CDC is updating COVID-19 guidance for adult day service centers. These centers provide important social and health services to community-dwelling adults age 65 and older, as well as to adults of any age living with disability. We know these populations are at high risk for severe COVID-19 disease, and this guidance will help center administrators and staff protect themselves and adults receiving their services by promoting and engaging in preventive behaviors that reduce COVID-19 spread and help maintain healthy operations and environments of these facilities. You can find the updated guidance and resources for center administrators and staff on the CDC website. It's up to us. It's up to all of us to be part of this solution. Thank you for hanging in there with us for just a little bit longer and for doing your part to help others. Thank you. I'll now turn things over to Dr. Fauci.
Thank you very much, Dr. Walensky. I'd like to spend the next couple of minutes talking to you about the subject of the potential role of vaccinations that we are currently giving in handling the variants that we see emerging in our society. Can I have the first slide? This is a slide which schematically diagrams the immune response to SARS-CoV-2. On the left-hand part of the slide is what happens when you get acutely infected. Multiple components of the immune response are operative. Antibodies, but also something we don't pay much attention to, and that is the cell-mediated response of what's called CD4 and CD8 cells. On the right-hand part of the slide is what happens when you recover, which is the state you try to mimic when you vaccinate an individual. In other words, you want to induce immune memory in the form of antibodies, CD4 and CD8 positive T cells, or what we call cell-mediated immunity, as well as memory B cells. Next slide. So what I want to talk about in the next 2 minutes or 3 minutes is that the immune protection against COVID-19 variants, which is of obvious concern to us, when you are vaccinated against a wild-type viral strain, namely the common virus in society. There are 2 potential mechanisms that protect you against variants. One, a high titer of antibody that, although it's specific against the wild-type strain, it is high enough that there's a spillover effect against the variant. And the second, which I'd like to emphasize right now, is the T cell response that, although it's specific against the wild-type strain, there's a considerable degree of cross-reactivity against a range of variants, which is characteristic of T cells. This slide here shows the high level of antibody against a prime and a boost of the Pfizer vaccine. The point I was making a moment ago is that that level is so high that even when you diminish it by multifold, which is the case with the variant, you still have a good degree of protection. Next slide. But the other thing that we want to concentrate on is that now we're learning more and more that these CD4 and CD8 cells are very important in that they cross-react against certain viral variants, and they last for a long time. Next slide. This slide is in individuals who are actually infected, showing that immune memory response lasts for several months, but it also includes, besides antibody, what I mentioned, the very important T cells, which can help against the variants. Next slide. When you look at vaccinated individuals, as shown on this slide, you get T cell memory response again against the variants, not only against the virus to which you were vaccinated against, but as shown in this report, against a number of variants. Next slide. And finally, in a paper that came out just yesterday, it was shown very clearly that in individuals who recover from infection, if you look at their CD4 and CD8 positive T cells, they recognize virtually all of the variants of concern. So on the final slide, next slide, getting back to what I said in the beginning, we are seeing now immune protection against COVID-19 variants when individuals are vaccinated against the wild type strain on two mechanisms: the antibody response that has a spillover effect, as well as the cross reactivity. The bottom line message to everyone is why it's so important to get vaccinated. Because vaccination is not only going to protect us against the wild type, but it has the potential to a greater or lesser degree to also protect against a range of variants. So when vaccination becomes available, get vaccinated. Back to you, Andy.
Thank you. That's great news. All right, let's take questions.
First question will go to Tamara Keith at NPR.
Thank you. Thank you so much for taking my question. What we're wondering about at NPR today is whether there might at some point, and I don't know that this point is yet, but whether at some point there might be a shift in the allocation of vaccine doses based on demand rather than simply on population size. If there are, pockets of the country where demand is a little bit more slack, and there are other areas where there's a lot of demand and not enough supply, whether there might be a calibration that you guys are now starting to consider.
That's a great question, Tamara. And without signaling anything specific, I want to answer that question at a high level. I think you're exactly right. We're going to go through stages as we vaccinate higher and higher portions of populations where it will make sense for us to continue to watch where vaccines are needed, how vaccines are distributed, the best way to reach more people. And we will be in a situation, unlike one we're familiar with in the last couple of months, where we have an abundance of vaccines. So I might not think of it as much as shifting, as much as I might think of making sure that we're putting enough vaccines in all the places that they're needed, including doctors' offices, including regions, including places that might have been inefficient to do at the beginning while we had a surplus. So it is absolutely how you should be thinking about our approach going forward. Next question.
Stephanie Baker, Bloomberg.
Thank you. Yes, this is a question for Dr. Fauci. Can you explain why you decided to issue a public statement questioning the AstraZeneca interim results? And do you think that their updated results will enable them to secure emergency use authorization? Because I think many countries around the world that are relying on the AstraZeneca vaccine will be taking their lead from the FDA, even if Astra doses are not used in the U.S. And then just another quick question. When do you expect the UK variant to become the dominant variant in the U.S.? Thank you.
Well, with regard to, to your first question, I believe you're referring to the NIH statement that followed the letter that was sent by the DSMB to AZ, as well as with a copy to me. I did not have a statement questioning their data at all. I urged them to make sure that their data was up to date in the sense that the DSMB had written to them a rather harsh note saying they did not believe that the data that was in their press conference was the most recent updated data. The only statement that we made in our release was to encourage them to work closely with the DSMB to make sure that the data that they put into their press release is the most update and accurate data. So I didn't question their data at all. I just urged them to work closely with the DSMB. And I'm sorry, your second question?
I think the second question was related to variants, and I can just sort of fill you in. B117, we know from our most recent data, is about 26% of circulating virus right now. We are looking at it by region. It varies in region from 4 to 35%. And so we're watching this very carefully, but it is starting to become the predominant variant in many U.S. regions.
I think your final question was asking us to consider whether the FDA was going to grant an EUA. Obviously, we're going to leave that to the FDA, but I'm wondering if, Dr. Fauci, you have any additional comments given the data that you have seen relative to the AstraZeneca release?
Well, the data that they made public most recently indicates to me that this is a good vaccine that is going to have a very important role in the global response to this outbreak.
Thank you. Next question.
Next, we'll go to Lauren Klassen at CQ Roll Call.
Hi, thank you. Yes, two questions. First, given the rise in cases in a number of schools and states that are reopening, how important is it to have a national testing strategy, and when should we expect to see that? And then secondly, are you anticipating any medical supply chain disruptions stemming from the backlog in the Suez Canal? Thank you.
Okay. The first question on schools and testing, Dr. Walensky, do you want to provide some input into that?
Yeah, what I will say is we're watching, obviously, the cases by jurisdiction. Our school-based reopening strategy does look at community transmission and is guided based on community transmission. We have 5 mitigation strategies and, of course, ancillary mitigation strategies related to teacher vaccination and testing, as you note. And we're working closely with the Department of Ed and others to put forward a national testing strategy for schools.
In terms of your question about medical supplies in the Suez Canal, we'll get back to you if we hear differently, but none that I'm aware of, and we didn't have to send people over to dig the ship out, so we were able to keep them focused on getting people vaccinated. Let's go to the next question. By the way, let me just add one thing about the schools and the testing before I forget. I should remind everybody that last week we announced $10 billion in new testing dedicated directly to schools. So we now have the resources, thanks to the Congress and the bill signed by the President, to be able to vaccinate children on a weekly basis across the country. So that testing capability is there. The testing resource centers are developed and available, and the testing is quite there. So in addition to what Dr. Walensky said. Next question.
Sharon Lafreniere, New York Times.
Thank you for taking my question. I wanted to follow up with Dr. Fauci. What do you think, Dr. Fauci, about the decision yesterday by the German regulators to restrict the use of AstraZeneca's vaccine in people under 30 because of a rise in the number of cases of unusual blood clots? I think it's sinus vein thrombosis. Does that give you fresh concern or no?
Well, I only have to go back to the European Medicines Agency, the EMA, which again have made the statement that is their opinion that the clotting issues that were seen with the AZ, the frequency of that was no more than in the general population not associated with vaccines. So, I don't have any further opinion on that except to say that you're talking about a situation in the European Union, and the regulatory agency that's responsible for what goes on in the European Union feels that that is not an issue, that it is, in fact, the same level as you'd expect in the general population.
And let me just pile on to assure the public of the following. The FDA will conduct a completely thorough analysis of the application that's submitted and all the data from AstraZeneca. And Dr. Fauci, as he always does, will help the public interpret whatever comes out of the FDA when they review that data. So people should be very assured that we have the best regulatory bodies who study these matters in the world. We'll be looking at this data, and the best scientists in the world will help people understand whatever comes out of that. So I think we should wait until we see what happens with that process before anybody jumps to conclusions. Next question.
Jeremy Dinan, CNN.
Should we go to another question, Kevin?
We'll go to another question.
It wasn't letting me unmute, but it just did. Can you hear me?
Yes, Jeremy.
Okay, thank you. So two questions. First of all, you said that you expected the B117 variant to be dominant in the U.S. by the end of March, early April. Is it now the dominant strain, and how much of the increase in cases do you attribute to that variant? And then secondly, we've heard a lot from you about the importance of governors keeping or reinstating mask mandates. But several of the states experiencing the worst surges haven't done away with their mask mandates. Instead, it's been loosening of other restrictions like indoor dining and gatherings. So my question is, what are you telling states about which restrictions they should be implementing? And why haven't you published uniform gating criteria to lay out a roadmap that states should be following? Thank you.
Right. Dr. Walensky, do you want to take those?
As I mentioned earlier, we now have B117 as 26% of the circulating variant across the United States, and it is the predominant strain in at least 5 regions of the United States. So we're starting to see it creep up. We do know it's more transmissible, somewhere between 50 and 70% more transmissible than the wild type strain. So to the extent that people are not practicing the standard mitigation strategies, we do think that more infections will result because of B117. We believe that the current mitigation strategies of masking and distancing would work just as well against the wild type strain as they do the B117 strain. I think we've been pretty clear with regard to our guidance and strategies and setting specific strategies as to how people can remain safe in these settings. And we continue to articulate in these press conferences and others the importance of masking, distancing, not traveling, and decreasing crowds.
Yeah, let me just reiterate. I think 3 times a week for the last 10 weeks, Dr. Walensky has made the same points over and over and over again, because repetition is good and it's important. People want to know that they're getting consistent answers. And consistently, 3 times a week for 10 weeks, Dr. Walensky has said, wear a mask, avoid crowds, socially distance, and don't travel unless it's absolutely essential. 3 times a week for 10 weeks. We repeat that in all our conversations with governors. We repeat that in all our conversations with local officials. And we're not the only ones saying it. Public health officials from departments and agencies across the country make the same points, so that people who are in violation of that are choosing to do that. They're not confused about where we stand. And to your point, Jeremy, that's not the only factor that drives case growth. And even where there are mandates, not everyone complies by them. But where the variants are at any given time is obviously also another important factor. Next question.
We're going to squeeze one more question in. We'll go to Sikan Akpan at New York Public Radio.
Hi, thank you for taking my question. So New York health officials continue to voice concerns about the B1526 variant. Early studies suggest this variant was first detected last November, and it now represents a large proportion of cases in New York City and New Jersey, namely in counties undergoing surges. Yet the CDC still classifies B1526 as a variant of interest rather than a variant of concern. I'm wondering what additional evidence is needed before B1526 is classified as a variant of concern. Does the CDC plan to release state-by-state case numbers on the New York variant rather than just a rough proportion? And what's the national tally of B1526 cases so far?
Thank you for that question. I'm going to have to get back to you on the details on the national tally. What I will say is that there is an interagency group that looks at these variants and classifies them, and it is that interagency group CDC is a part of that is actually looking at exactly this question right now.
Thank you. Thank you all. I want to just take the opportunity for us to wish everyone on the call a happy holiday season and a safe holiday season. Thank you very much.
Okay, we've been talking about making sure that we have an equitable response from out of our government and from our governor bodies around the world to make sure that everybody is being treated equally and getting equal treatment, medical treatment during the pandemic, and making sure that these programs are put in place in a way that they will last, so that the equitable treatment for medical treatment will last well past a pandemic and help protect the global population against future pandemics, because as we know, this isn't the first one to happen, and this probably will not be the last one. So there have been some issues that were brought up about some of the vaccines causing side effects that actually could possibly threaten human life. People taken to have blood clots that and these blood clots are happening while there's low platelets, which means that with the platelets being lower, that it's harder to treat the patient so that you can stop the clotting from happening. By just simply using blood thinners may not be necessarily the most effective treatment. They have to figure out different ways to actually stop the clotting so that they can save lives. So there was one vaccine that did have this problem. We'll hear about that in a second, and how Canada responded to actually delivering, using the vaccine, that they have several doses of it so that it can be effective in causing immunity in Canada against COVID-19. So why don't we listen to a technical briefing from the Canada federal health agencies and the federal government from out of Ottawa. So let's listen to that and see how Canada reacted to such things, data of a vaccine causing such a side effect. So here we go.
Today we will hear from Dr. Howard New and Major General Danny Fortin from the Public Health Agency of Canada. They will be accompanied by Joël Paquette from Public Services and Procurement Canada. Aujourd'hui, nous aurons des allocutions des Dr. Howard New et du Major Général Danny Fortin de l'Agence de la santé publique du Canada. Ils seront également accompagnés de Joël Paquette de Services publics et Approvisionnement Canada, qui sera disponible pour répondre aux questions. Following the remarks, we will open the teleconference line to questions from the media. Suite à la présentation, il y aura une période de questions. Procédons maintenant à la séance d'information technique. Let's begin today's technical briefing. Over to you, Dr. New.
Okay, thank you. Merci, Eric. Hello, everyone, and thank you for joining us at today's technical briefing on Canada's COVID-19 vaccine rollout. I'm here with Major General Danny Fortin, Vice President of Operations and Logistics at the Public Health Agency of Canada. We will each provide brief remarks and then open the floor to questions. To assist us in addressing your questions, we have with us Joël Paquette from Public Services and Procurement Canada. To date, almost 5.7 million doses of COVID-19 vaccines have been administered in Canada. Among those over 80 years of age, 73% have received their first dose and 9.3% have received their second. And among those 70 to 79, 33% have received their first dose and 1.8% have received their second. What we are seeing in terms of vaccine rollout is encouraging. Regular deliveries of COVID-19 vaccines to and within Canada and the growing number of vaccinations being administered are positive signs in the fight against COVID-19. The rate of our progress in curbing COVID-19 in Canada, however, is subject to a mix of variables. As more and more people are vaccinated, for instance, we can expect that the data and recommendations on the use of vaccines will continue to evolve. This week, Health Canada, the National Advisory Committee on Immunization, and the Chief Medical Officers of Health issued statements with revised recommendations regarding the use of the AstraZeneca vaccine. In response to such changes, provinces and territories must decide how to apply the revised recommendations, taking into consideration factors including the latest and best evidence available. Health Canada and the Public Health Agency of Canada have a robust national vaccine safety monitoring system, engaging healthcare professionals, vaccine manufacturers, provincial and territorial health authorities, Indigenous partners, and the public. When a new potential safety concern or adverse event following immunization is brought to our attention, thorough examination and assessment occurs to determine if the event is related to a vaccine. If necessary, prompt, appropriate action is taken. As of March 26, there have been a total of 2,859 reports of adverse events following immunization. This figure represents 0.06% of doses administered. These reports include any adverse medical event that occurs following immunization, but is not necessarily related to the vaccine or the immunization process. A total of 384 of these reports, or about 1 in 13,000 doses given, were considered serious, such as a severe allergic reaction. To date, no unexpected vaccine safety issues have been identified in Canada. In addition to assuring you of our commitment to keeping you informed, I encourage you to recognize this latest adjustment to guidance on vaccine administration for what it is, an outcome of our robust safety monitoring system and ongoing global collaboration. Passover has begun and the Easter weekend is approaching. These are times when Canadians traditionally gather with family and friends. That's why I must also remind you of another necessary part of our collective effort to prevent the spread of COVID-19 in our communities. Throughout the country, we are seeing numerous cases and outbreaks of the virus. Increasingly, these involve strains that are variants of concern. This is an important time for all of us to maintain our commitment to what we're working so hard to achieve, keeping COVID-19 at bay in our communities. It is critical that we all keep following the important public health measures such as physical distancing and wearing a mask. Because the extent to which vaccines may prevent the onward spread of the virus has not yet been fully determined, this has to apply to everyone in Canada, including those of you who have received your first and even your second dose of vaccine. Please hang in there a while longer. We've come too far to let our guard down now. Thank you. Bonjour à toutes et à tous et merci de participer à la séance d'information technique d'aujourd'hui sur le déploiement des vaccins contre la COVID-19 au Canada. Je suis accompagné par le Major général Danny Fortin, vice-président des opérations et de la logistique à l'Agence de la santé publique du Canada. Nous vous fournirons quelques renseignements, puis nous passerons aux questions. Pour nous aider à y répondre, Joël Paquette, de Services publics et Approvisionnement Canada, est ici également. Jusqu'à présent, près de 5,7 millions de doses de vaccins contre la COVID-19 ont été administrées au Canada. Chez les personnes de plus de 80 ans, 73% ont reçu leur première dose et 9,3% leur deuxième. Chez les personnes de plus de 70 à 79 ans, 33% ont reçu leur première dose et 1,8% leur deuxième. En ce qui concerne le déploiement des vaccins, la situation est encourageante. Les envois réguliers de vaccins contre la COVID-19 vers le Canada et à l'intérieur du pays, ainsi que l'augmentation du nombre de vaccins administrés sont des signes positifs dans la lutte contre la pandémie. Cependant, la vitesse à laquelle nous réussirons à faire reculer la COVID-19 au Canada dépend d'une combinaison de variables. À titre d'exemple, à mesure que le nombre de personnes vaccinées augmentera, les données et les recommandations sur l'utilisation des vaccins continueront d'évoluer. Cette semaine, Santé Canada, le Comité consultatif national de l'immunisation et les médecins hygiénistes en chef ont publié des communications contenant des recommandations révisées sur l'utilisation du vaccin d'AstraZeneca. À la suite de ces changements, les provinces et les territoires doivent décider de la façon d'appliquer les nouvelles recommandations en tenant compte de certains facteurs, notamment des dernières et meilleures données probantes à leur disposition. Santé Canada et l'Agence de la santé publique du Canada disposent d'un excellent système de surveillance à travers le pays de l'innocuité des vaccins qui met à contribution les professionnels de la santé, les fabricants de vaccins, les autorités sanitaires des provinces et des territoires, les partenaires autochtones, ainsi que le public. Lorsque nous sommes informés d'un nouveau problème d'innocuité possible ou d'un événement indésirable associé à la vaccination, nous procédons à une évaluation approfondie afin de déterminer si l'événement est lié à un vaccin. Si des mesures s'avèrent nécessaires, nous agissons rapidement. Au 26 mars, 2859 événements indésirables associés à la vaccination avaient